or head and neck tumors. Now, all of these principles of management in terms of diagnosis and treatment are applicable to any tumors in other areas of the head and neck. What we have just presented is one patient with a preauricular mass. But these principles are applicable for any mass located in other areas of the head and neck outside this preauricular area. Example, if you have a mass in the perihyoid area, what would be the possible organs or tissues of origin? Dr. Boa.
Consider, first of all, the possibility of a congenital lesion, such as thyroglossaldaxis.
Any other possible organs or tissues of origin?
Aside from that, I would also consider a lymph node.
So the first step would be to determine the possible organs or tissues of origin based on the location. And after that, you just try to determine what is the most probable organ or tissue of origin of the mass. Then after that, you try to come up with a more specific clinical diagnosis. Example, if the perihyoid mass is cystic in nature, then you think of a thyroglossaldaxis. So your diagnosis of the thyroglossaldaxis is very specific. Now, another example of how you can utilize the basic principles and approaches we have brought out will be a neck node or a mass located in the peristernocleidomastoid area. As you know, this is most likely a lymph node. Okay. So the lymph node is the tissue of origin. Okay. And after that, you consider all the possible pathologies. Okay. Now, if you have a lymph node on the neck, what are the usual 4 considerations as far as the disease is concerned? Dr. Cristobal?
Consider of a metastatic tumor, usually from the thyroid.
What are your other considerations, Dr. Cristobal, besides a metastatic lymph node?
Primary tumor, metastatic tumor, inflammatory.
Anything else, Dr. Jananaka?
My consideration is non-specific lymph nodes.
So non-specific lymphadenopathy, metastatic lymphadenopathy, and what was the last one that you mentioned? Metastatic inflammatory. Anything else from Tondo? Good.
In addition to that, I'm also thinking of lymphoma or a TB, due to TB.
Okay, so if you have a lymph node on the neck, on the lateral side of the neck, the usual considerations, 4 considerations would be a non-specific lymphadenopathy, metastatic lymphadenopathy, lymphoma, or a tuberculous lymphadenopathy. Then based on the characteristics, the specific findings on your physical examination, then you try to decide which one is the most probable diagnosis. So at this point, we're practically through with the what we intend to achieve this afternoon. Do you have any questions from the audience from Zamboanga City?
I think there are no questions at the moment, right? So we just continue.
Okay. So let me just give you a recap or synthesis of what we have taken up so far. First is the approach to the diagnosis of head and neck tumor. So the basic approach will be try to answer these various questions. First, is there really a tumor? Second, if there is a tumor, where is it located? Then the third question will be, based on the location, what is its organ or tissue of origin? Now, the answer can be derived by using the characteristics of the mass, such as consistency, and the other diagnostic process, such as looking for a primary focus to explain a secondary lymphadenopathy. Now, the next question to ask would be, what is the cause of the tumor? That is, after you have identified the possible organ or tissue of origin. Now, for this particular question, you try to answer this question first. Is it inflammatory? And to answer this question, you look for inflammatory signs, physical signs of inflammation. If there are physical signs of inflammation, then your diagnosis is that you're dealing with an inflammatory tumor. Now, if there are no physical signs of inflammation, the next question to ask, is this a malignant tumor? And to answer this question, we look for physical signs of malignancy. And the usual physical signs of malignancy are, 1, a hard consistency. 2nd, signs of local invasions, which can be in the form of fixation, nerve paralysis, or skin ulceration. Another sign of malignancy is a sign of spread, either to the regional lymph node or to distant areas or both. Now, if there are no physical signs of malignancy, then you settle for a benign tumor, which is the last option you have, or last choice. Now, the reason why you would go accept a benign neoplastic diagnosis in the absence of physical signs of inflammation and physical signs of malignancy, as you have mentioned, benign tumors are still more common than malignant tumors. And the other clue which you can use, which is very reliable, is the cystic nature of the mass. If you have a cystic nature of the mass, then you go for a benign neoplastic diagnosis. Now, after you've decided that it is either an inflammatory tumor, malignant tumor, or benign tumor, you can go over one step further by trying to give a histopathic diagnosis. You can do this by utilizing 1, pattern recognition, meaning the usual manifestation of a particular disease. 2nd, you can use prevalence. 3rd, you can use your personal experience. If you have seen such a case, such a tumor before, then it's easy to make a diagnosis the second time around. Now, we also discussed the indications of paraclinical diagnostic procedure and the general indications. As we said, if you are not quite certain of your clinical diagnosis, as a rule, you go for a paraclinical diagnostic procedure. If you're quite certain of your clinical diagnosis, then you don't have to go for a paraclinical diagnostic procedures. And some of you mentioned the exceptions to the rules, which are rational. Now, we also discussed the selection of a paraclinical diagnostic procedure. In brief, we mentioned about accuracy, sensitivity, specificity, availability, expense, risk, or complications. Now, for head and neck tumors, as a rule, when you're dealing with bony tumors, you usually order for a radiologic examination as a paraclinical diagnostic procedure. For non-bony tumors, you usually order for a biopsy procedure. We also discussed the rational use of frozen section and also the treatment. For inflammatory tumor, if it is in the IV stage, you just give analgesics, antibiotics, or anti-inflammatory agents. For those in the abscess stage, you do an excision drainage procedure. For benign neoplasm, you do an excision. For malignant neoplasms, in the surgical treatment, you try to consider primary tumor as well as the neck node. Okay. For the primary tumor, the usual treatment is a wide excision. And the indication for reconstruction is that there's a huge defect which cannot be closed primarily. And the indication for resection is that there are palpable or clinically evident lymph nodes which are suspicious for metastasis. Are there any questions, reactions from the audience from Zamboanga?
It's a concept of knowledge with the presence of Dr. Peter from Calgary, Canada. He's observing right now and taking some pictures. With regards reactions or comments, I think all our points were taken, and I think there are no questions at the moment.
Okay, I'd like to say hi to Peter. Now, before we formally close this teleconference, I'd like to thank the following people. The residents from Tondo Medical Center and Zamboanga Medical Center, thank you for your participation and congratulations for passing this teleconference. Actually, it's an oral exam for you people. I'd also like to thank the audience for their interest in this teleconference. Here, the audience here are the residents from Tondo, but in Zamboanga, I heard we have a lot of audience who came over. I'd like to thank the medical students, 27 medical students who joined the group, who joined the conference this afternoon, as well as Dr. Peter from Canada. And lastly, I'd like to thank Dr. Arturo Pisigan for letting us use their facilities in the telemedicine project of the UP College of Public Health. I hope this is not the last time. So, on that note, I end this teleconference. Unless we have Dr. Pisigan still here with us, would you like to say something, Dr. Pisigan? I'd like to turn the mic to Dr. Pisigan.